Welcome to our channel. I am going to discuss facial bones. First I will explain the maxilla. It is a paired bone of the facial skeleton, and it has a body and four processes. The two maxillary bones or plural maxillae are fused in the midline by the intermaxillary suture to form the upper jaw. Each maxilla has 5 parts, including the body of the maxilla and 4 processes. Frontal process. Zygomatic process. Palatine process. Alveolar process. The body of the maxilla is the central portion of the bone housing the maxillary sinus and supporting the forementioned processes of the maxilla. The body of the maxilla has 4 surfaces: anterior, orbital, nasal, and infratemporal surfaces. The anterior surface of the body features nasal notch, infraorbital margin, infraorbital foramen, canine fossa. The nasal notch is a curved margin of the bony anterior nasal aperture. And the infraorbital margin is the lower margin of the orbit formed partly by the maxilla, and partly by the zygomatic bone. The infraorbital foramen is an opening on the anterior aspect of the maxilla located below the infraorbital margin. It is the outer opening of the infraorbital canal that serves as the passage for the infraorbital nerve, which is a branch of the maxillary nerve, accompanied by the infraorbital artery and vein. The canine fossa is a depressed area on the anterior surface of the body located below the infraorbital foramen. The canine fossa is the origin site of the levator anguli oris muscle. The orbital surface of the body of the maxilla forms most of the floor of the orbit and features the infraorbital groove leading into the infraorbital canal. This canal ends with an opening on the anterior surface of the maxilla and serves as the passage for the infraorbital nerve and blood vessels, as mentioned before. The nasal surface of the body of the maxilla forms part of the lateral wall of the nasal cavity and features a large defect or opening, the maxillary hiatus. The maxillary hiatus is an opening to the maxillary sinus, located below the middle nasal concus. The maxillary sinus is a paranasal sinus, an air-filled cavity located within the body of the maxilla. The infratemporal surface of the body of the maxilla features the maxillary tuberosity with alveolar foramina that lead into the alveolar canals. The maxillary tuberosity, or maxillary eminence, is a rounded eminence at the lower part of the infratemporal surface. It is the origin site for a few fibers of the medial pterygoid muscle. The alveolar foramina are several small openings on the maxillary tuberosity leading into the alveolar canals, several small bony passages, that transmit the posterior superior alveolar nerves, which are branches of the maxillary nerve, and posterior superior alveolar arteries and veins to the upper teeth. Processes of maxilla. Each maxilla is composed of 5 parts. Besides the central part known as the body, the maxilla has the following 4 processes. Frontal process. Zygomatic process. Palatine process. Alveolar process. The frontal process is an extension of the maxilla projecting upward, medially, and backward for articulation with the frontal bone. The frontal process of the maxilla features the lacrimal groove. Situated on the frontal process of the maxilla and the lateral surface of the lacrimal bone, the lacrimal groove participates in forming the nasolacrimal canal. It houses the nasolacrimal duct. The zygomatic, malar, process of the maxilla is the lateral extension of the bone for articulation with the zygomatic bone. Posterior part of this process is concave and participates in forming the infratemporal fossa. Anteriorly, it forms part of the anterior surface of the maxilla. The palatine process of the maxilla is an extension of the maxillary bone shaped as a horizontal plate forming the largest part of the hard palate. Joins the palatine process of the opposite maxilla at the median palatine suture. The opening of the incisive canal can be found on the palatine process. It starts as a paired canal from the floor of the nasal cavity and unites with the palate in the uniform incisive fossa. From each incisive canal ascends the terminal branch of the greater palatine artery, and descends the nasopalatine nerve. An alveolar process is a crested process of the upper or lower jaw which houses the teeth. The curved free margin of the alveolar process is called the alveolar arch. The alveolar arch of the maxilla, as the alveolar arch of the mandible, features the following structures. Dental alveoli. Interalveolar septa. Interradicular septa. Alveolar yolks. The dental alveoli are sockets in the alveolar process where the roots of the teeth lie. The dental alveoli of the mandible house the roots of the lower teeth, while the dental alveoli of the maxilla, the upper teeth. The interalveolar septa are bony ridges between adjacent dental alveoli. But the interradicular septa are bony ridges forming compartments in dental alveoli for the roots of the teeth in both the upper and lower jaw bones. The alveolar yolks, or juga alveolaria, are eminences on the outer surfaces of the jaw bones produced by the projections of the dental alveoli. They can be seen on alveolar processes of both the maxilla and the mandible. Development and ossification. The maxilla develops from intramembranous ossification. Initially forms as two halves, which fuse at the intermaxillary suture during early fetal development. Clinical relevance. Maxillary fractures. Common in facial trauma, often associated with Le Fort fractures. Le Fort I, horizontal fracture above the alveolar process. Le Fort II, pyramidal fracture involving the nasal bridge, maxilla, and orbital floor. Le Fort III, craniofacial disjunction involving the zygomatic arch and nasal bones. Sinusitis. Infection or inflammation of the maxillary sinus can lead to facial pain and nasal congestion. Dental problems. Tooth abscesses or alveolar bone resorption may impact the structure and function of the maxilla. Cleft palate. A congenital defect where the palatine processes of the maxilla fail to fuse properly, leading to an opening in the hard palate. Nasolacrimal duct obstruction. Abnormalities in the lacrimal groove or nasolacrimal canal can lead to tear drainage issues. That's the end of anatomy of maxillary bones. Now I am going to discuss zygomatic bone. The zygomatic bone, also known as cheek bone or malar bone, it is a paired facial bone situated in the upper lateral part of the face. This bone participates in creating the prominence of the cheek. The zygomatic bone also takes part in forming the floor of the orbit, as well as the temporal fossa and infratemporal fossa. Each zygomatic bones articulates with four bones: maxilla, temporal bone, sphenoid bone, and frontal bone. Each zygomatic bone has four margins, three surfaces, orbital, temporal, lateral or facial, and three processes, frontal, temporal, maxillary, or orbital. The bone houses the zygomatic canal for the passage of the zygomatic nerve and blood vessels. Here are the borders of zygomatic bone. Surfaces of zygomatic bone. The orbital surface shown in red box of the zygomatic bone forms part of the lateral side of the orbital floor, inferior wall of the orbit. The orbital surface presents an opening called the zygomatico-orbital foramen. The zygomatico-orbital foramen continues as the zygomatic canal leading to both zygomatico-temporal and zygomatico-facial foramina. The temporal surface of the zygomatic bone is directed posteriorly and medially. It is concave and medially presents a surface for articulation with the zygomatic process of the maxilla. Laterally, it has a concave surface that forms the anterior border of the infratemporal fossa. Near the center of the temporal surface is the zygomatico-temporal foramen. It is an opening near the base of the frontal process that leads into the zygomatic canal and is a passage for the zygomatico-temporal nerve. It provides attachment for the temporalis muscle which involved in mastication. The lateral surface of the zygomatic bone is also known as the facial surface, and it is faced towards the outside. It participates in forming part of the infraorbital margin, partly formed by the zygomatic bone, partly by the maxilla. The facial surface of the zygomatic bone features the zygomatico-facial foramen, usually, one or two openings, near its center. However, it can sometimes be absent. This foramen leads into the zygomatic canal and is a passage for the zygomatic nerve and blood vessels. It provides attachment for the zygomaticus major and zygomaticus minor muscles, which are involved in facial expression. Processes of zygomatic bone. The frontal process of the zygomatic bone is a superiorly oriented extension that unites the zygomatic bone with the zygomatic process of the frontal bone. It also participates in forming the lateral outline of the orbital opening. The temporal process is a posteriorly directed process that connects with the zygomatic process of the temporal bone to form the zygomatic arch. Prominent zygomatic arches appear as a facial feature that we call high cheekbones. The maxillary process, sometimes called the orbital process, extends anteriorly and forms a part of the infraorbital margin and a small portion of the anterior part of the lateral orbital wall. Posterior to this process is the orbital surface of the zygomatic bone. Foramina of the zygomatic bone. Zygomatico-orbital foramen. Located on the orbital surface. Divides into the zygomaticofacial and zygomaticotemporal foramina, transmitting branches of the zygomatic nerve. Zygomaticofacial foramen. Located on the lateral surface. Transmits the zygomaticofacial nerve and vessels. Zygomaticotemporal foramen. Located on the temporal surface. Transmits the zygomaticotemporal nerve and vessels. The zygomatic bone articulates with four bones. Frontal bone, superiorly, at the frontozygomatic suture. Temporal bone, posteriorly, at the zygomaticotemporal suture, forming the zygomatic arch. Maxilla, anteriorly, at the zygomaticomaxillary suture. Sphenoid bone, medially, at the zygomaticosphenoidal suture shown in upper left box. Development and ossification. The zygomatic bone develops through intramembranous ossification from three primary centers. 1. Orbital center. 2. Maxillary center. 3. Temporal center. These centers fuse during fetal development. Clinical relevance. Zygomatic fractures. Often caused by facial trauma, such as in car accidents or sports injuries. Fractures may involve the zygomatic arch, orbital floor, or maxilla. Symptoms include facial asymmetry, difficulty opening the mouth, trismus, or infraorbital nerve damage causing numbness in the cheek. Zygomaticomaxillary complex, ZMC, fractures. Involve the zygomatic bone, maxilla, frontal bone, and orbital bones. Commonly referred to as a tripod fracture and can impair orbital function. Cosmetic surgery. The zygomatic bone is often a focus in facial reconstructive and cosmetic surgeries, such as cheek augmentation. Temporomandibular joint disorders. The zygomatic arch provides attachment for muscles affecting the TMJ, and abnormalities in this region can contribute to TMJ dysfunction. That's the end of zygomatic bone anatomy. Now it's time to discuss nasal bone anatomy. The nasal bones are a pair of small, rectangular-shaped bones located in the upper central part of the face. They form the bridge of the nose and contribute to the upper portion of the nasal cavity. Though small, they play a crucial role in providing structural support to the nose and serve as attachment points for various facial muscles. The nasal bone articulates with four bones. Two of them are bones of the neurocranium, the frontal bone and ethmoid bone, and two are bones of the viscerocranium, the opposite nasal bone and the maxilla. The nasal bones are variable in size and form in different individuals. Each nasal bone has two surfaces, outer and inner, and four borders, superior, inferior, medial, lateral. Here we can see four borders. Superior border. Articulates with the frontal bone at the frontonasal suture. Inferior border. Connected to the lateral nasal cartilage, contributing to the flexibility of the nasal structure. Lateral border. Articulates with the maxilla, forming part of the nasal aperture. Medial border. Fuses with the opposite nasal bone at the internasal suture, forming the midline of the nasal bridge. External surface or anterior surface. Is convex and smooth. Provides attachment for the procerus and nasalis muscle, which helps in facial expressions like frowning. It forms the visible bridge of the nose. Internal surface or posterior surface. Is concave and rough. Contributes to the formation of the nasal cavity. It features a groove for the nasociliary nerve, a branch of the ophthalmic division of the trigeminal nerve. The nasal bones articulate with four bones. To the frontal bone, superiorly, at the frontonasal suture. To the maxillae, laterally, forming part of the nasal aperture. To the ethmoid bone, posteriorly, at the upper part of the perpendicular plate. To the opposite nasal bone, medially, at the internasal suture. Development and ossification. The nasal bones develop through intramembranous ossification. They begin to ossify during the second month of fetal development. The size and shape of nasal bones vary between individuals and contribute to differences in nose shape. Clinical relevance. Nasal bone fractures. Most commonly fractured facial bones due to their prominent position. Occur due to trauma, for example sports injuries, falls, or direct impact. Symptoms: pain, swelling, nasal deformity, bruising around the eyes, raccoon eyes, and difficulty breathing through the nose. Rhinoplasty, nose surgery. The nasal bones are often reshaped or repositioned during cosmetic or reconstructive surgeries. Deviated nasal septum. Sometimes associated with irregular nasal bone development, causing breathing difficulties. Congenital anomalies. Cleft nose deformity may involve abnormal nasal bone development. Craniosynostosis syndromes, conditions like Apert syndrome can affect nasal bone growth. Now I am going to discuss lacrimal bone. The lacrimal bone is a small, paired facial bone that contributes to the medial wall of the orbit and forms part of the nasolacrimal canal, which is involved in tear drainage. It is the smallest and most fragile bone of the face and plays a crucial role in the lacrimal apparatus, allowing tears to drain from the eye into the nasal cavity. Anatomy of the lacrimal bone. The lacrimal bone is thin and rectangular in shape. It has two surfaces, four borders, and contributes to the lacrimal groove and nasolacrimal canal. Surfaces of the lacrimal bone. The lateral surface of the lacrimal bone, also known as the orbital surface, is divided by a vertically oriented bony projection called the posterior lacrimal crest. Anterior to the posterior lacrimal crest lies a vertical groove known as the lacrimal groove. The lacrimal groove is a groove for the nasolacrimal duct in the anterior part of the lateral surface of the lacrimal bone, and it continues on the frontal process of the maxilla. The medial wall of the groove has a descending extension that contributes to the formation of the nasolacrimal canal. The lacrimal groove of the lacrimal bone fuses anteriorly with the posterior border of the frontal process of the maxilla to form a fossa that houses the lacrimal sac. The medial surface of the lacrimal bone, also called the nasal surface, presents a longitudinal ridge corresponding to the lacrimal crest on the lateral surface. The anterior region of the lacrimal bone's medial surface forms a part of the middle nasal meatus. Borders of the lacrimal bone. It has four borders: anterior, posterior, superior, inferior borders. Anterior border. Articulates with the frontal process of the maxilla. And forms the anterior part of the lacrimal groove. Posterior border. Articulates with the lacrimal process of the ethmoid bone. It forms the posterior part of the lacrimal groove. Superior border. Articulates with the frontal bone, contributing to the orbital rim. Inferior border. Joins the lacrimal process of the inferior nasal conchus, completing the nasolacrimal canal. Development and ossification. The lacrimal bone develops through intramembranous ossification. It ossifies early in fetal development from a single ossification center. Clinical relevance. Lacrimal bone fractures. Due to its small and fragile nature, the lacrimal bone is prone to fractures, especially in orbital trauma. Fractures may damage the nasolacrimal duct, leading to tear drainage issues, epiphora. Nasolacrimal duct obstruction, NLDO. Blockage of the nasolacrimal canal can lead to excessive tearing and eye infections. Common in newborns but can also occur due to trauma, infections, or tumors. Dacryocystitis, infection of the lacrimal sac. Inflammation of the lacrimal sac due to nasolacrimal duct obstruction. Symptoms include swelling, pain, redness, and discharge near the inner corner of the eye. Surgical interventions. Dacryocystohenostomy, DCR, a surgical procedure to create a new drainage pathway for tears if the nasolacrimal duct is blocked. That's the end of lacrimal bone anatomy. Now palatine bone. The palatine bone is a paired L-shaped bone located at the back of the nasal cavity, forming part of the hard palate, nasal cavity, and orbit. It plays a crucial role in separating the oral and nasal cavities, contributing to the structure of the skull. Anatomy of the palatine bone. Each palatine bone consists of 2 plates and 3 processes. Here we can see it anterior, posterior, medial and lateral view. Processes of the palatine bone are: pyramidal process. Projects laterally and fits into the pterygoid fossa of the sphenoid bone. Orbital process. Contributes to the floor of the orbit. Articulates with the sphenoid and maxilla. Sphenoidal process. Extends superiorly and articulates with the sphenoid bone. Helps form the sphenopalatine foramen, which connects the nasal cavity to the pterygopalatine fossa. Plates of the palatine bone. Here is horizontal plate shown in red box. It is the horizontal part of the palatine bone that forms the posterior portion of both the hard palate and the floor of the nasal cavity. Here shows its 4 borders. The horizontal plate of the palatine bone has 2 surfaces, nasal surface and palatine surface. The nasal surface of the horizontal plate forms part of the posterior portion of the nasal cavity's floor and part of the inferior nasal meatus. The palatine surface forms part of the bony palate and features greater palatine foramen that leads to the greater palatine canal, and lesser palatine foramina that lead to the lesser palatine canals. The greater palatine foramen is a small opening in the horizontal plate of the palatine bone which serves as a passage for the greater palatine nerve coming out from the greater palatine canal into the oral cavity. The greater palatine canal goes through the palatine and sphenoid bones, connecting the pterygopalatine fossa to the oral cavity. It transmits the descending palatine vessels, the greater palatine nerve, and the lesser palatine nerve. Lesser palatine canals branch off from this canal. The lesser palatine foramen refers to one or more small foramina representing the openings in the hard palate, more precisely, in the horizontal plate of the palatine bone. This opening or openings lead to the lesser palatine canal running vertically through the perpendicular plate of the palatine bone. These canals carries the lesser palatine vessels and lesser palatine nerves. Perpendicular plate. It is the vertical part of the palatine bone. It forms part of the medial wall of the maxillary sinus. Here we can see its 4 borders. The perpendicular plate has 2 surfaces, nasal surface and maxillary surface. This plate also features the sphenopalatine notch. The maxillary surface is rough and irregular, and articulates with the nasal surface of the maxilla. It forms a strong suture with the maxilla, specifically with the nasal surface of the maxilla. This connection helps form the pterygopalatine fossa, a crucial area for neurovascular structures. A shallow vertical groove runs on the maxillary surface. This groove, when joined with the corresponding groove on the maxilla, forms the greater palatine canal. The greater palatine canal transmits the greater palatine nerve and vessels, which supply the hard palate and nasal cavity. The posterior part of the maxillary surface contributes to the pterygopalatine fossa. This fossa is an important region for the maxillary nerve, pterygopalatine ganglion, and blood vessels. In some cases, a lesser palatine groove may be present on the maxillary surface. When completed by the maxilla, it forms the lesser palatine canal, transmitting the lesser palatine nerves and vessels. The nasal surface of the perpendicular plate forms the supero-posterior part of the nasal septum. Superiorly, it articulates with the cribriform plate of the ethmoid bone. The sphenopalatine notch is a deep notch located on the perpendicular plate of the palatine bone, between its orbital and sphenoidal processes. At the point where the palatine bone articulates with the body of the sphenoid bone, the notch converts into the sphenopalatine foramen, which connects the nasal cavity with the pterygopalatine fossa. The nasal surface contains two crests, which serve as attachment sites for the nasal conchae, turbinates. Ethmoidal crest or superior conchal crest. Located in the upper part of the nasal surface. Articulates with the middle nasal conchus of the ethmoid bone. Helps form the middle nasal meatus, which is involved in nasal airflow regulation. Inferior conchal crest. Located in the lower part of the nasal surface. Articulates with the inferior nasal conchus, a separate bone that helps warm and filter air. Forms the inferior nasal meatus, where the nasolacrimal duct opens. Development and ossification. The palatine bone ossifies intramembranously. It develops from a single ossification center in the embryonic period. Completes fusion in early childhood, contributing to skull stability. Clinical relevance. Cleft palate. A congenital defect where the palatine bones fail to fuse properly. Leads to difficulty in feeding, speech problems, and increased risk of infections. Often requires surgical repair. Palatine bone fractures. Can occur due to facial trauma, affecting the hard palate or pterygoid region. May lead to difficulty swallowing, nasal regurgitation, or nerve damage. Greater palatine nerve block. Anesthetic injections at the greater palatine foramen are used in dental procedures to numb the posterior palate. Sinus and nasal disorders. The palatine bone contributes to the nasal cavity, and any deformity can impact breathing and sinus drainage. That's the end of palatine bone anatomy. Inferior nasal concha. The inferior nasal conchus, also called the inferior turbinate, is a paired, scroll-like bone located in the lateral wall of the nasal cavity. It is one of the three nasal conchae, turbinates, along with the middle nasal conchus and superior nasal conchus, which are part of the ethmoid bone. Unlike the other two conchae, the inferior nasal conchus is an independent bone. Anatomy of the inferior nasal concha. It found in the lateral wall of the nasal cavity. Extends horizontally and forms part of the inferior nasal meatus. It curves medially to help direct and filter airflow in the nasal cavity. The inferior nasal conchus separates the middle nasal meatus from the inferior nasal meatus. Each inferior nasal conchus has two surfaces, medial, lateral, two borders, superior, inferior, and two extremities, anterior, posterior. Here is anterior, posterior, medial and lateral view. Surfaces of the inferior nasal concha. Medial surface, faces the nasal cavity. It is convex and covered by respiratory mucosa. It plays a key role in air filtration, humidification, and temperature regulation. Its hypertrophy or enlargement. A cure from chronic allergies or infections leads to thickening of the mucosa, result in nasal congestion. It may require surgical reduction, turbinate reduction surgery. The lateral surface is concave, irregular and participates in forming the inferior nasal meatus. Borders of inferior nasal concha. Superior border, articulates with surrounding bones, maxilla, ethmoid, palatine, and lacrimal. The superior border of the inferior nasal conchus is thin and irregular, and it can be divided into three regions, an anterior region that articulates with the conchal crest of the maxilla, a posterior region that articulates with the conchal crest of the palatine bone, and a middle region with three processes, lacrimal, ethmoidal, maxillary. Lacrimal process. Located near the anterior part of the bone. Helps form part of the nasolacrimal canal, which drains tears from the eyes into the nasal cavity. Ethmoidal process. Located superiorly, articulates with the ethmoid bone. Sometimes connects with the uncinate process of the ethmoid bone. Maxillary process. Extends laterally, articulating with the maxilla. Forms part of the medial wall of the maxillary sinus. The inferior border of the inferior nasal conchus, on the other hand, is free, thick and spongiose. Both the anterior and posterior extremities of the inferior nasal conchus are narrowed ends of the bone, the posterior being narrower than the anterior. The inferior nasal conchus articulates with 4 bones. It articulates with maxilla anteriorly, helping form the nasal cavity. With ethmoid bones superiorly, where the ethmoid's uncinate process sometimes connects. With palatine bone posteriorly, contributing to the hard palate. An inferior nasal conchus articulates with lacrimal bone at the junction of the lacrimal groove, near the nasolacrimal duct. Clinical significance. Nasal obstruction and deviated concha. An enlarged inferior nasal conchus, hypertrophy, can cause nasal congestion and breathing difficulties. May require turbinate reduction surgery. Chronic sinusitis and allergies. Inflammation of the mucosa covering the inferior nasal conchus can contribute to sinus infections and allergic rhinitis. Treated with nasal corticosteroids, antihistamines, or surgery if severe. Inferior nasal concha fractures. Trauma to the nasal area can fracture the inferior nasal conchus, leading to airway obstruction or excessive bleeding. Role in tear drainage problems. Blockage of the nasolacrimal duct, which drains tears below the inferior nasal conchus, can cause excessive tearing, epiphora. May require surgical correction, dacryocysterhinostomy. Now I am going to discuss vomer bone anatomy. The vomer bone is an unpaired midline bone of the skull. Along with the perpendicular plate of the ethmoid bone, the vomer forms the bony nasal septum. It helps divide the nasal cavity into right and left halves and plays a crucial role in nasal structure and airflow regulation. Anatomy of the vomer bone. Here we can see vomer bone, the skull bone removed. The vomer is quadrilateral in shape. Positioned vertically within the nasal cavity. Forms the lower portion of the nasal septum, with the perpendicular plate of the ethmoid bone forming the upper portion. Here we can see its anterior, posterior, medial AMD lateral view. The vomer has 2 surfaces. Right surface, faces the right nasal cavity. Left surface, faces the left nasal cavity. Both surfaces are similar in structure and function. Both surfaces are smooth, flat, and covered with nasal mucosa. Small grooves run along both surfaces, accommodating branches of the sphenopalatine artery and the nasopalatine nerve. These structures supply blood and sensory innervation to the nasal septum. The vomer is covered by respiratory epithelium, which traps dust, allergens, and pathogens. The vomer works with the perpendicular plate of the ethmoid bone and cartilaginous septum to maintain septal stability. The vomer has 4 borders. Superior border is thick and expanded. It articulates with perpendicular plate of the ethmoid bone, forming the upper part of the nasal septum. It also articulate with sphenoid bone, via the rostrum of the sphenoid. Superior border contains the ali of the vomer, 2 small wings that attach to the sphenoid bone. Inferior border is thin and free. It articulates with palatine process of maxilla and horizontal plate of palatine bone. Inferior border helps separate the nasal cavity from the oral cavity. Anterior border is slender and vertical. It articulates with perpendicular plate of the ethmoid bone and cartilaginous nasal septum, extends forward to form the flexible part of the septum. Posterior border is free and vertical. It does not articulate with any bone. Posterior border forms the posterior nasal aperture, choanine, allowing air to pass into the nasopharynx. The vomer articulates with 6 bones. Ethmoid bone, at the perpendicular plate, forming part of the nasal septum. Sphenoid bone, at the sphenoidal rostrum and vomerine wings. Maxilla, inferiorly, helping separate the nasal and oral cavities. Palatine bone, inferiorly, forming part of the nasal floor. Cartilaginous nasal septum, anteriorly, contributing to the flexible part of the septum. Nasal crests of the maxilla and palatine bones, inferiorly, for additional support. Clinical significance. Deviated nasal septum. If the vomer is misaligned, it can lead to a deviated septum, causing breathing difficulties, nasal congestion, snoring and sleep apnea. Severe cases may require septoplasty, surgical correction. Fractures and trauma. The vomer is thin and fragile, making it prone to fractures in facial trauma. A fractured vomer can affect nasal airflow and septum alignment. Role in nasal surgeries. The vomer is often involved in nasal septum surgeries and rhinoplasty. Removal or reshaping of the vomer may be necessary in cases of septal perforation. That's the end of vomer bone anatomy. Now the mandible bone. The mandible, or lower jawbone, is the largest and strongest bone of the human face. It plays a crucial role in chewing, speech, and facial structure. The mandible is the only movable bone of the skull, articulating with the temporal bones at the temporomandibular joints, TMJ. Anatomy of the mandible. The mandible consists of body, which is the horizontal, curved portion. Rami, singular, ramus, is two vertical extensions from the body. Processes, includes the condylar process, articulates with the temporal bone, and the coronoid process, attachment site for muscles. Here is the anterior, posterior, medial and lateral view. Body of mandible. The body of the mandible is the horizontal, U-shaped part of the mandible, lower jawbone. It supports the lower teeth, contributes to chewing and speech, and provides attachment points for important muscles. The body of the lower jawbone has two surfaces, external, internal, and two borders, superior or alveolar, and inferior or base. Inferior border or base of the mandible. The base is the lower part of the body of the mandible, excluding the alveolar part. The base of the mandible has an external and an internal surface. Functions of the inferior border. Is to maintains jaw strength and structure. Provides attachment for the digastric muscle, which assists in jaw movement and swallowing. External surface or outer surface. The features found on the external surface of the mandibular base are mental protuberance, two mental tubercles, two mental foramen. The mental protuberance is a prominence found on the outer surface of the mandible forming the chin. On either side of the mental protuberance, is a prominence known as the mental tubercle. Together the mental protuberance and mental tubercle create a landmark known as the mental trigone. The mental foramen is an opening in the lower jawbone located below the second premolar tooth. This opening serves as the passage for the mental nerve, a nerve that arises from the inferior alveolar nerve, which itself is a branch of the mandibular nerve, CNV3. Functions of the external surface. Is to provide attachment for facial muscles, including those involved in chewing and speech. Mental foramen allows passage of sensory nerves and blood vessels to the face. Internal surface or inner surface. The internal surface of the mandibular base also features several anatomical landmarks, including mental spine, two digastric fossa, two mylohyoid lines, two sublingual fovea, two submandibular fovea. The mental spine is a bony elevation on the inner surface of the mandible projecting toward the tongue. The mental spine is the origin site of the genioglossus and geniohyoid muscles. The digastric fossa is an oval depression on the lower internal surface of the mandibular body on either side of the middle line. It is an attachment site for the anterior belly of the digastric muscle. The mylohyoid line is a paired oblique ridge extending from the posterosuperior to anteroinferior aspect of the body of the mandible. It is the origin site of the mylohyoid muscle, and its posterior part is the origin of the myelopharyngeal part of the superior pharyngeal constrictor. The sublingual fovea is a depression on the inside of the mandible for the sublingual gland, one of the salivary glands. It is a paired structure found on the anterior half of the body of the mandible below the mylohyoid line. The submandibular fovea is a depression on the mandible's inner surface for another salivary gland, the submandibular gland. This fovea is also a paired structure. It is found on the posterior half of the mandibular body below the mylohyoid line. Alveolar part of mandible. The alveolar part or alveolar process of the mandible is the portion of the mandibular body that surrounds and supports the lower teeth. An alveolar process is a crested process of upper or lower jaw which houses the teeth. The curved free margin of the alveolar process is called the alveolar arch. The alveolar arch of the mandible, as the alveolar arch of the maxilla, features the following landmarks. Dental alveoli. Interalveolar septa. Interradicular septa. Alveolar yolks. The dental alveoli are sockets in the alveolar process where the roots of the teeth lie. The dental alveoli of the mandible house the roots of the lower teeth, while the dental alveoli of the maxilla, the upper teeth. The interalveolar septa are bony ridges between adjacent dental alveoli. But the interradicular septa are bony ridges forming compartments in dental alveoli for the roots of the teeth in both the upper and lower jaw bones. The alveolar yolks, or juga alveolaria, are eminences on the outer surfaces of the jaw bones produced by the projections of the dental alveoli. They can be seen on alveolar processes of both the maxilla and the mandible. Clinical significance of body of mandible. Mandibular fractures. The body of the mandible is prone to fractures from trauma, falls, or accidents. Common fracture sites, near the mental foramen or molar region. Treatment, requires wiring, plates or screws for stabilization. Tooth loss and bone resorption. The alveolar process undergoes bone resorption after tooth loss. This can lead to facial changes and difficulty in wearing dentures. Solution: dental implants help preserve bone structure. Nerve damage, mental nerve injury. Injury to the mental nerve, during surgery or trauma, can cause numbness in the lower lip and chin. Mandibular osteomyelitis. Infection of the mandible, often caused by dental infections or fractures. Requires antibiotics or surgical drainage. Ramus of mandible. The ramus of the mandible is the vertical, quadrilateral extension of the mandible that rises from the body on each side. It plays a critical role in chewing, jaw movement, and muscle attachment. Each ramus of the mandible has an internal and external structures, and features several major landmarks like angle of mandible, condylar process, which features head of the mandible, neck of the mandible, pterygoid fovea, coronoid process, mandibular notch. The angle of the mandible, also known as the gonial angle, is the angle seen on each side of the mandible. It is the junction between the body and ramus of the mandible. The condylar process is an articular process of the ramus that articulates with the disc of the temporomandibular joint. It features three structures: the head and neck of the mandible, and the pterygoid fovea. The head of the mandible is the articular part of the condylar process. The neck of the mandible is a narrow segment of the condylar process below the mandibular head. And the pterygoid fovea is an anteromedial pit below the head of the mandible, where the lateral pterygoid muscle attaches. The coronoid process is a muscular process located anteriorly to the condylar process of the mandible. The condylar process is thicker than the coronoid process. The temporalis muscle attaches to the coronoid process. The two processes, coronoid and condylar, of mandible are separated by a depression known as the mandibular notch. The internal surface of the mandibular ramus features some important landmarks as well, which are inferior alveolar foramen, mandibular foramen, mylohyoid groove, pterygoid tuberosity. The mandibular foramen is an opening on the inner surface of the mandibular ramus leading into the mandibular canal, a bony passage in the lower jawbone that transmits the inferior alveolar artery and nerve. The mylohyoid groove or sulcus is a groove seen on the internal surface of the mandible extending forward and downward from the mandibular foramen. This groove is the passage for the mylohyoid nerve and the mylohyoid branch of the inferior alveolar artery. The pterygoid tuberosity is a roughened area occasionally present on the internal surface of the ramus near the angle of the mandible. The medial pterygoid muscle attaches to the pterygoid tuberosity. The external surface of the ramus of the mandible features a roughened area known as the masseteric tuberosity. It is occasionally present near the angle of the mandible. This is an attachment site for the masseter muscle. Clinical significance. Mandibular fractures. The ramus is less prone to fractures than the body but can break due to trauma. Fractures usually occur at the condylar process or angle of the mandible. Treatment may require wiring or surgery for proper alignment. Temporomandibular joint, TMJ, disorders. The condylar process forms part of the TMJ, which can develop pain, clicking, or limited movement. Causes include arthritis, teeth grinding, bruxism, or jaw misalignment. Inferior alveolar nerve injury. Damage to the inferior alveolar nerve, near the mandibular foramen, during surgery can cause numbness in the lower lip and chin. Mandibular foramen and anesthesia. Inferior alveolar nerve block, used in dentistry, involves injecting anesthesia near the mandibular foramen to numb the lower jaw. Hyoid bone. The hyoid bone is a U-shaped bone located in the anterior neck, between the mandible and larynx. It is unique because it does not articulate with any other bone, instead being suspended by ligaments and muscles. The hyoid plays a crucial role in swallowing, speech, and tongue movement. The hyoid bone consists of body or central part, which is the largest part, forming the base of the bone. Hyoid bone has greater horns, greater cornua, which are two long projections extending posterolaterally. And lesser horns or lesser cornua, which is two small projections extending upward from the body. Now we'll discuss its part one by one. The body of the hyoid bone is the central and largest part of the bone. It is flattened and rectangular in shape. It has two surfaces. Anterior surface is slightly convex, provides muscle attachment. While posterior surface is concave, supports adjacent structures. Body serves as an attachment site for muscles involved in swallowing and tongue movement. Supports the tongue and larynx. Greater horns or greater cornua. Extend backward and slightly upward from the body. Act as attachment points for muscles and ligaments of the tongue and pharynx. Greater horns help stabilize the hyoid bone. Provide attachment for hyoglossus, thyrohyoid, and middle pharyngeal constrictor muscles. Lesser horns or lesser cornua are small conical projections extending upward from the junction of the body and greater horns. They are connected to the styloid process of the temporal bone via the stylohyoid ligament. Lesser horns act as a pivot point for movements of the hyoid. Provide attachment for the stylohyoid ligament, which helps suspend the hyoid in position. Clinical significance. Hyoid bone fractures. Rare, usually caused by strangulation, direct trauma, or hanging. Can result in difficulty breathing, swallowing, and speaking. Hyoid syndrome. Chronic pain in the hyoid region, often due to muscle strain or ligament irritation. Role in forensic medicine. Hyoid fractures are a strong indicator of strangulation in forensic investigations. Speech and swallowing disorders. Dysfunction of the hyoid or its associated muscles can lead to speech impairments and dysphagia, difficulty swallowing. So, that's end of facial or viscerocranium bone anatomy.